Hi everybody, my name is Andy Katcher at NOFAS, the National Organization on Fetal Alcohol Syndrome, and I'd like to welcome everyone to this edition of the NOFAS webinar series. And this webinar is presented by Dr. Gwendolyn Messer, and it's on the topic of the relationship between FASD and ADHD, fetal alcohol spectrum disorders, and attention deficit hyperactivity disorder. And there's three learning objectives that I'd like to just review quickly. One is recognize the association between prenatal alcohol exposure and the development of ADHD. We're also going to be understanding the complicating factors in the diagnosis and treatment of ADHD in children with prenatal alcohol exposure, and learning the skills to be an active participant in ensuring appropriate treatment and optimal outcomes for children with ADHD and FASD. So just to give a brief introduction of our presenter, Dr. Gwendolyn Messer. She's an MD Medical Director at Children's Research Triangle and received her medical degree at Emory University School of Medicine, and Dr. Messer joined Children's Research Triangle in 2005 and became the medical director in 2010. Dr. Messer works with Children's Research Triangle to provide comprehensive evaluation for children with developmental or behavioral concerns, including children who have been prenatally exposed to drugs or alcohol or who have suffered trauma. In addition, Dr. Messer provides medical management for children with complex ADHD and other behavioral disorders. Dr. Messer is committed to raising awareness about fetal alcohol spectrum disorder and has presented locally and nationally to professionals and parents on topics related to FASD, ADHD, and domestic and international adoption. And I'd just like to add some specific info related to Dr. Messer's association and support with NOFAS, the National Organization on Fetal Alcohol Syndrome. So she has worked and supported NOFAS for many years. She's a dedicated clinician with lots of experience working with children prenatally exposed to alcohol, leading international expert on getting the right, accurate diagnosis for FASD and ADHD and how those conditions may interact. So a little background with NOFAS: she's worked on a project at Children's Research Triangle, which was featured in a recent NOFAS brochure that was published that included 4 evidence-based treatments. And she worked on a project called PACT, Parents and Children Together, which is one out of the 4 featured interventions featured in that brochure. And that intervention focuses on self-regulation and executive functioning. Also, Dr. Messer was very supportive when NOFAS implemented the first medical school curriculum for FASD in the United States. And this was at Northwestern University's Feinberg School of Medicine, and she was very supportive of that class and was a lecturer at the class and graciously allowed the medical students, to visit her clinic at Children's Research Triangle and witness firsthand how to intervene and support children with FASD. So she's been a longtime true friend of NOFAS and a friend to struggling families living with FASD. And this topic of FASD and ADHD is one that's very important to many families. We're very happy to have Dr. Messer presenting this information. So I'll turn the webinar presentation this time over to Dr. Messer.
Well, thank you for that very kind introduction. Sometimes I forget about all of the things that we do here at CRT, so that gives a nice recap of that. So let's get started. We've already been through, you already outlined the learning objectives, which is good. So we're just going to get right into the meat of the subject. We're going to talk about medications, and so this is always included. I have no relationship with anybody as far as prescribing one particular medication or another. So we are going to talk about this interaction between fetal alcohol spectrum disorders and ADHD. This is not going to be a talk on the basics of FASD, but we are going to touch base a little bit to make sure that we are all on the same page. One of the key issues is to understand how important alcohol is in impacting neurobehavior in children. It is more impactful than any other prenatal substance exposure that we know about. And understanding that and why that is puts a little bit of a background, a basis for understanding what we're doing here. So alcohol is a teratogen, and what that means is it's a substance that interferes with the development of the fetus. And it can interfere in a variety of ways. It impacts or can impact the formation and appearance of the face. It has an impact on growth. It can impact other areas of the body. But the most important thing that we work with is how it impacts the central nervous system. And essentially, the prenatal exposure changes the way the body puts the brain together during the fetal period. And it does it in a variety of ways, and all of those contribute to what we see then after the children are born. So when we look at all the different ways that alcohol has an impact, it has an impact on what's called apoptosis, which is cell death. So every baby, there are more brain cells created in the formation of the brain than should be there. And in all fetuses, there's a process of pruning back and honing those down. But the problem is, when exposed to alcohol, more of those cells die off than are supposed to. And to compound that problem, fewer of the cells are actually created than we're supposed to. So we have decreased nerve cell proliferation. Now we've got fewer nerve cells from both of those causes. In addition, where a nerve cell is born in the brain, essentially, where it is created, is not necessarily where it belongs. Nerve cells are created in one place and then they have to migrate to the appropriate place in the brain, and the alcohol negatively impacts that migration too. So we've got all of these structural things going on with the nerve cells themselves. In addition, the alcohol impacts the neurotransmitter system, which is the chemical way that those brain cells, once they are put into a network, communicate with each other. And so what we get is an impact on the central nervous system, both in the size of the brain, because we have fewer neurons, the structure of the brain because of the problems with nerve cell migration, as well as the function of the brain from the changes in the neurotransmitter system. So the brain is being hit by alcohol in multiple different ways, and it's being affected by all of those things. Now, if we move on to the ADHD piece of this, we're going to go to some basic definition to make sure that we are all on the same page as to what this is. So ADHD is a persistent pattern of inattention, hyperactivity, impulsivity that interferes with functioning or development. Now, those two words are highlighted on purpose, because this is not just a child who occasionally does not pay attention or is overactive. This is an ongoing thing, and by definition, it has to have been ongoing for at least 6 months. And it really needs to interfere. It has to cause some negative impact on the child in order for it to be ADHD as we define it. So when we look at the actual criteria, we need to see the symptoms during childhood. Now, it used to be that that was set at 7 years old. It's been advanced to 12 years old, but it's not something that happens in later years. The other thing is that it needs to be developmentally inappropriate, which means if we have a child who has lower cognitive abilities, we need to set our expectations for their attention, their activity level, etc., appropriately for their level of cognition. And that comes into play very much when we look at making a proper diagnosis. We also need to see these symptoms causing problems in more than one setting. It's not just about a child who misbehaves in the home setting or only in the school setting. And when we see that, when we see the behaviors limited to one setting, that is a red flag to say that's probably not ADHD, and we need to look for something else that it actually may be. We talked about that it needs to interfere with functioning. And I want to stress here, and I'm going to stress a couple of times through this presentation, that this is not just, we want this child to do better in school. This is not a treatment to make their behavior better so they're more manageable in the school setting, or only so they can do their homework and learn and get better grades. We're talking about functioning in life. We're talking about the quality of that child's life in all areas. School and academics obviously are very important, but we are looking at family and peer relationships. We're looking at augmenting self-esteem, because you can imagine if you are going to school and interacting in your life and in the community with significant ADHD symptoms, how that may be impacting self-esteem because you're not as successful as you could be. So again, not just to make things better in school. And then we get to not better accounted for by another disorder. And this is where we're going to work through this in the process of this talk, looking at, can it be, quote, better accounted for by something such as prenatal alcohol exposure or not? And anyway, we're going to go through that. So that's kind of the key to this piece, is how that might interact with another disorder that the child may have. So I am not reading through all of these. These are the examples given as a reference as what we're talking about when we say inattention. There are 9 different categories. We need 6 from any particular category in order to comply with the definition of ADHD. But what I want you to look at on this slide is the word often and how it appears in, yes, every single one of these. And it is not none of these can be an occasional issue. All of us occasionally fail to pay attention. We occasionally get distracted. This is a persistent pattern that we're looking for if we're going to make a diagnosis in this area. And the same thing happens with the hyperactive and impulsive category of things. This is something that's happening all the time. So it's happening all the time, it's happening in multiple settings, and it's causing a dysfunction for the child. And when we make this diagnosis, we look at those different categories. We're supposed to count up how many there are, and then assign a category for it. Primarily inattentive, meaning basically the child who has issues with attention, distractibility, but is not hyperactive or impulsive. Primarily hyperactive and impulsive is something that I will say that it's there, and I've seen it occasionally, but that's not usually a diagnosis that gets made. The most common one is combined, where you've got the inattention and you have the hyperactivity and impulsivity too. So when we look at what do we need to do to properly make the diagnosis, and I will pause here and say that the diagnosis is often made in a way that may be too rushed, not comprehensive enough, because we need to look at a lot of different aspects of what's going on in order to make sure that we are getting to the right diagnosis. And that means the right diagnosis for ADHD as well as the right diagnosis for a fetal alcohol spectrum disorder too. The key to this is really gathering information. There is not a litmus test that we can do, certainly for ADHD, while there is for FAS itself, because all of the facial features, all of the face impact of prenatal alcohol exposure has to be present for a diagnosis of FAS. Within the umbrella of FASD, we have another diagnosis, which is alcohol-related neurodevelopmental disorder, which basically means that the child does not have all those facial features and yet still has the CNS impact, the central nervous system impact from prenatal alcohol exposure. So the diagnosis has to be made by information gathering. We need to talk to parents, to teachers, to other caregivers. When we're looking at different aspects for properly diagnosing FASD, we need to look at cognitive ability, sensory integration problems. There are a variety of issues that need to be examined closely so that we make an accurate diagnosis. And evaluating for a fetal alcohol spectrum disorder is something that really ought to be done in many children who have ADHD. And the reverse is true too. If a child has a diagnosis of FASD, the consideration should be given as to whether ADHD is going on as well. And what we're looking at is complex ADHD. And there are many people who would say that all ADHD is complex. And technically they're correct. Most kids who have properly diagnosed ADHD have other things going along with that, other challenges. But when I refer to complex ADHD, I'm talking about big challenges. I'm talking, as we are talking about here, about the child who has ADHD as well as a fetal alcohol spectrum disorder that's impacting many areas of their lives. Other issues is a child who has ADHD and trauma also can be a very complex case. But when we're looking at fetal alcohol spectrum disorders, we need to remember that the effects of alcohol are very variable, and every child presents differently, has his or her unique presentation as far as what aspects are presented, what issues and challenges they have, as well as how severe those challenges are. And it's important to know that when we put forth all of the things that are commonly seen in a child with an FASD, what that means is it's everything. But usually, the kids who walk through our door usually do not have every possible aspect of it. So it looks different in different children, which I think makes it complicated sometimes for people to understand all of the different pieces that can put together in one child. So one child who has a fetal alcohol spectrum disorder may look significantly different than another in all of these ways, and yet it's all coming from the impact of that prenatal alcohol exposure. So when we look at the disabilities that come from prenatal alcohol exposure, we categorize them into two big pots, let's say. So we've got the primary disabilities, and what that means is the direct effect that the alcohol has had on the developing brain. That's the teratogen part, how it changed that child's brain. But then we have secondary effects, and what those are is what happens to the child in society when that child interacts with all of these primary disabilities that came from the prenatal alcohol exposure. So in this graphic, we've got all of the different steps. Now, each step gives us the opportunity to intervene. I would love it if we would intervene before the prenatal alcohol exposure ever happened. FASDs are entirely preventable if we can prevent that prenatal alcohol exposure to begin with. However, once that has happened and we have progressed, I'm going to use my cursor here to guide us. When we've progressed down to here, the primary disability, we can't undo that. We can't undo the damage that was done to the brain by prenatal alcohol exposure. But we can intervene. We can change this part. We can change the progression from the primary disability down to dysfunctional behavior by providing that child and that family with the appropriate interventions that they need for that particular child's presentation of a fetal alcohol spectrum disorder. And by doing that, by changing this, the hope is we can preclude, to at least a large extent, this progression down to secondary disability. The part where we get kids who have significant issues in school that aren't being addressed. Perhaps move on to legal issues, other behavioral issues. And in order to do that, we need to get the right treatments to address those primary disabilities and manage the dysfunctional behavior in order to stop that. So the first thing to understand on this slide is increased risk. ADHD is one of those primary disabilities. It is a direct result of the prenatal alcohol exposure to the brain. In our clinic, we see somewhere between 50 and 75% of our kids who have an FASD also have ADHD. Now, our clinic is a little bit distinct because there are other pieces going on here as well. A lot of our children have experienced trauma, may have other things going on that are impacting them. But even if we take that out, even if we pull that piece out, the The background risk in the population, now this depends a little bit on whose study you read, but it's going to say it ranges, say, between 4 and 7% in the background population for ADHD, and that may even be a little bit high, but let's say it is 4 to 7%. In our kids with fetal alcohol spectrum disorder, we're looking at least at 40% and probably more than half. Probably significantly more than half of those children have ADHD in addition to their fetal alcohol spectrum disorder. And the presentation in that case is more complicated because we've got all of what's coming from the ADHD, but we also have all of the issues that are coming from the prenatal alcohol exposure. And many of those symptoms that you see in those disorders, they overlap. So if we are looking at hyperactivity, impulsivity, inattention, all of those things can come from a variety of causes. They could be coming directly from the ADHD itself, but they also could be coming from the sensory integration disorder that may be associated with kids who've been prenatally alcohol exposed. Or it could be executive functioning issues, which can come either from the ADHD or the FASD. It could also come from intellectual functioning problems. So there is a lot of overlap, and we really need to sort that out in order to provide appropriate treatment. And we're going to talk about that treatment a little bit later in this presentation. But the question becomes, why isn't it easy to tell which one it is? Does this child just have a fetal alcohol spectrum disorder, just have ADHD, or are they both occurring together? And the reason it's hard to tell is because of the overlap of symptoms. All of these different areas of central nervous system impairment in FASD are all things that can masquerade as ADHD. They can be misdiagnosed as ADHD, or they really can be ADHD along with the fetal alcohol spectrum disorder. So if I do a checklist, perhaps for ADHD, and for a child who doesn't have that but has a fetal alcohol spectrum disorder, the checklist may look the same. But we need someone who understands both of those disorders to kind of get in there, sort things out, and help determine which it is, one, the other, or both. So when we're looking at cognitive functioning, so I want to stress the cognitive functioning piece itself is not going to be directly related to the ADHD. Prenatal alcohol exposure is the only substance we have that directly impacts cognitive functioning. So we're talking about a lower IQ. And that's not going to be directly associated with the ADHD, but there really can be overlap because the child, for instance, who has not yet been identified as having an intellectual disability, yet is attending school, that child may be hyperactive, inattentive, distractible, but not necessarily because of ADHD. It may be because they have not yet been identified and the proper educational supports have not been put into place. So that's where cognitive functioning fits in as far as things being confusing between these two disorders. And then we've got executive functioning. Those of you who are familiar with FASDs are very familiar with all of these things because executive functioning is markedly impacted in our kids who have prenatal alcohol exposure in all of these different areas that you see on the slide. Some of the big things, though, with an FASD, one of the biggest is abstract thinking. That cause and effect connection is also markedly impacted. But the thing you need to know is that executive functioning is also very impacted in kids who have ADHD. So we have to figure out which of these things are which and not erroneously say that just because they have them, that they fit into one category or the other, instead being aware that they can come from both. Another issue that we see in both disorders, perhaps coming from different places, are behavioral issues such as lying, stealing, having poor frustration tolerance, anger and aggression. Now, those people who are not familiar with a fetal alcohol spectrum disorder oftentimes will lump these behavioral issues under ADHD immediately. But the understanding needs to be had that they also appear in children with fetal alcohol spectrum disorders. Similarly, when we're looking at social emotional issues, there is inherently a higher rate of depression and anxiety in kids who have FASDs. They have trouble with social interactions, understanding social cues. But the thing to know is our kids who have ADHD that's not properly treated, they also have social issues. They are running into kids. They're not paying attention to what's going on, and it really does impact their social engagement as well. And then there's sensory integration dysfunction. And this is kind of how it feels to be a child who can't process sensory information properly. And there's a huge overlap in this. The child who is under-responsive, so sensory information is coming at her, yet she doesn't seem to respond to it. That could look a lot like inattention that we see in ADHD. While over-responsiveness, the child who every little thing has him bouncing off the walls, that could be sensory integration issues and need sensory integration treatment. Yet it could also be the hyperactivity and fidgetiness that we see with ADHD. So the complexity of this is because of the overlap of all of these symptoms. So then, why is it important to diagnose which issue it is? Is it one? Is it other? Is it both? And the reason is that it changes things. It guides effective treatment. The person that is treating either of these or both of these issues needs to understand the other one as well, because it changes what we do. If we are working on behavioral therapy interventions with a child who has ADHD, and we haven't yet recognized that the child also has FASD, some of the interventions that might be suggested are really not going to work. When I talk to people about this, and oftentimes someone's sitting in my clinic and telling me, we've tried everything, and I say, well, what is everything? And they start to describe how they've been working with this child, say, in therapy. And honestly, and I've said this on numerous occasions, that they might as well just be running their head smack into a brick wall thinking that somehow they're going to get through that wall. Because they're not. And it's not that we can't get to the other side of that wall and fix the issue that is going on. That's not what I'm saying. What I'm saying is that we need to go around the wall, tunnel under the wall, go over the wall. We need to find a different method of getting to what we want to get to that takes into account both diagnoses. Knowing both diagnoses when they're together allows people to set appropriate expectations, allows them to address issues that might be coming from each of those diagnoses, and hopefully prevent some of those secondary disabilities that we were talking about that impact children when their issues are not properly addressed. So when we're looking at the impact of ADHD, and I want to point out that many of these circles or ovals, many of these categories are issues that we also see as impact from FASD. There is a lot of things going on when children's ADHD is not recognized and properly treated. It can have a very strong impact on them. Now, one of these things that I want to point out, and this is one of, we're going to get to myths and truths towards the end of the presentation, but I just want to skip there for one moment related to this particular circle here of substance abuse, because this is a question I get asked all of the time when we're talking about treating ADHD in a child who has been prenatally substance exposed. The question is, since my child was prenatally substance exposed, I don't want him or her to go on and use substances, and I'm worried that by treating the ADHD pharmacologically, it could lead to that. And the answer is a resounding and huge no. The research has shown that kids who have ADHD that is not treated are much more likely to go on to use substances as well as engage in other behaviors that are problematic. And you can imagine why that's true. We've got a disorder, an ADHD, that's causing impulsivity, that's leading to poor decision making. And now we head into the teenage years and we've got lots of bad decisions being made. Whereas when we've treated those issues, we at least allow that child the opportunity to think before making a choice, things like that. Now, as I tell my patients, medication does not cause a child to behave well. The idea is that we want to impact that by allowing that child the opportunity to make a better choice than she may have if her ADHD was not properly treated. So, we're back to why do we treat it? Why do we treat ADHD in a child who has a fetal alcohol spectrum disorder? Well, the first reason is because treatment works. Now, there is some misinformation out in cyberspace that those kids with a fetal alcohol spectrum disorder cannot be treated for ADHD, and that is simply incorrect. Treatment absolutely does work. It doesn't work exactly the same as it might have if that child didn't have a fetal alcohol spectrum disorder, but it does work. Another reason we treat ADHD is because our kids who have an FASD, they already are faced with a lot of challenges and burdens in many cases that we wish they weren't. We wish that they had not been prenatally alcohol exposed and didn't have to deal with whatever pieces of their challenges are coming from that. But they are. And if there is a piece, even if it's only a small piece, of that burden that we actually can fix in a particular way, then we should. And we do that in many aspects of FASD. When they have educational needs, we go in and we try to address those. When they have sensory integration disorder, we go in and we provide sensory integration therapy. Similarly, when they have ADHD, we want to go in and provide treatment for that so that we can ameliorate that piece of their presentation. Now, another aspect is that many of our kids who have an FASD need other interventions, other therapy. And a lot of kids, if they have untreated ADHD, they have a hard time taking advantage of those treatments. It's really hard to provide therapy for a child who's bouncing off the walls. And I've had many kids in my practice where therapy was deemed that they just couldn't do it. The child just couldn't participate. But once we got the ADHD piece under better control, now that child could take advantage of these other things. Similarly, that happens in the educational setting. The child who's all over the place and can't pay attention may not be able to take advantage of the educational adjustments that are made to address the FASD part. So, when we are treating, how are we doing that? Well, in our kids with a fetal alcohol spectrum disorder, it has to be a team approach. And I don't know how many of you recognize the little girl in the middle, but her name is Amelia Bedelia. She comes from children's stories, and she is a very concrete thinker, gets in all sorts of mischief, and she reminds me very much of my kids who have a fetal alcohol spectrum disorder, as well as those who have both. So she is in the center of the circle. She is the goal. She is how we all make decisions on what we're going to do, is for her benefit. She's also part of the team. And in my clinic, once a child is able to start interacting with me when I'm treating the ADHD piece of things, her input is invaluable for me. Her experiences, how she experiences her medication, and many times kids, they can't tell me, and that's normal too, but how she experiences school, how she experiences her interactions with others. She's part of the team. And equally, we need parents, we need teachers, we need the physician, we need caregivers, and we need other people, any therapists who are involved. And they all have to be aware of what's going on with the ADHD piece as well as with the FASD piece if we're going to meet our goal for treatment. And that goal for treatment for both disorders, for the ADHD, for the FASD, and for whatever else may be going along with that, is to improve functionality across settings. Essentially, we want to make the child's life better. And it happens through addressing the challenges that he or she is showing. So are we seeing disruptive behavior? If so, that's one of our goals, the goals that we should set as a target. We want to see better attention and focus, and we want to specify what those goals are so that everybody knows what we're looking at. And we want to know that it's in school, as I told you before. We want better learning, but we also want better social engagement. We want the child to be better able to interact with his teacher. We want a child to be better able to interact with her peers. We want to impact self-esteem as well as actual learning. And again, it's not just school. We're looking in the community. We want the child to be able to participate in extracurricular activities. We want better relationships at home with siblings, with parents, better opportunity to form friendships. We're looking at functionality in all settings. And the way to do that is to create an individualized, multimodal treatment plan. Individualized for what that child needs. And that means all of the different modalities that are mentioned here at the beginning. Which one does the child need? They don't all need all of these, but we need to pick out carefully, and by understanding that child's presentation, which of these things is needed. And then when we get down to the medication piece, it is equally needs to be individualized. So when I'm prescribing medication, there is, yes, a general protocol that tends to work for most kids. But that tends to work for most kids. That means I have many kids in my practice where that particular structure is really not that effective. And then we go and we individualize. We individualize the dosing, the timing, the medication itself, as well as pulling in all of these other multimodal parts that are necessary for proper treatment. Now, we're going to move on to the medication aspect, because the medication is what we're using to treat the ADHD primarily. Yes, we want behavioral interventions. Yes, we want accommodations in school. Those are all important. But we also really need the medication piece, because without it, those interventions typically are not as effective as they could be. And when we're looking at medications, the first line is stimulant medication. Now, I cannot tell you how much I wish that the medications for ADHD were categorized under some other name other than stimulant, because how many times I have sat with a parent whose eyes get big and say, you know, the last thing they want is Johnny on something that's called a stimulant, since he's already bouncing off the walls. We don't need to stimulate him to do anything else. That's the name of the category, and yet that's not the effect of the medication. The stimulants, they tend to be demonized in many ways. Overall, they are very safe medications, and they are very effective. They are the most effective medications for the use in ADHD compared to any other treatment method. There's a variety of types of them that can be used. And the other important thing to know is that there's, even within one particular medication, so in the what I call the Ritalin family, that has a lot of different formulations of methylphenidate, or the Adderall family that has a lot of different formulations of that particular medication. Within that, these medications can be immediate release, they can be intermediate release, immediate, intermediate release, or extended release. And what that means is we're looking at the timing of the medication, how quickly they come in, how long they stay, as far as treating the symptoms go. And when we talked at the last slide about individualizing treatment, That's what we're talking about, is putting together a regimen of medication that appropriately covers symptoms over the course of time that the child needs those needs that symptom coverage. When we're looking at other treatments, and these other treatments listed here, these are second line. They are for kids who do not tolerate the stimulants for whatever reason. They are for the kids for whom stimulants are not effective, if they have side effects that cannot be managed. Most kids, on stimulants, most kids, the side effects can be managed and addressed, but certainly not in all. So in those children, we can move on to other treatments. One is atomoxetine, that's called Strattera. Another are alpha agonists. But again, the thing to understand is that those medications do not tend to work as well as the stimulants. So they are our second choice. And when we manage medication, it needs to be through active medication management. And the summary question for that is the treatment helping the whole child? That's what I really want to know. But when I'm following up, I need to look at all of these aspects. So these are all pieces of an active medication management plan. We need a physician who's familiar with both disorders, who understands that treating little children, which sometimes is necessary, versus school-age children versus adolescents is not all the same. We need to make sure that the goals of treatment are set realistically, and we need to recheck them. If we're going to say that a treatment failed, we better understand if it really failed, or were our target symptoms off? Were our target symptoms actually coming from the fetal alcohol spectrum disorder piece of it, in which case the treatment isn't going to work? We always need to look at the timing because of what I told you about the medications sometimes being short-acting. So I've had kids come in and parents think the medicine's not working, when in fact the medication that's being given is the type that only lasts for 3 or 4 hours, and the parent isn't seeing the child until it's completely out of the system. We need to make sure that follow-up is adequate, that there's the ability to communicate between visits. So for instance, in my practice, especially because I'm in Chicago and it's difficult for many of my patients to get here every 3 months that I see them, I don't want things to happen where somebody comes in at 3 months and said, oh, we've been having all these problems for 2 whole months. So we've set up a system where they can call and make a telephone appointment. Insurance does not cover it, but we've set it at a very reasonable rate because I don't want to have patients waiting a long time in between to address issues that might come up. And then we continue to educate and we continue to pay attention to everything that's going on. The FASD, of course, the ADHD, of course, but then what other things might be happening that we need to address that are impacting the child? And all of these things have to be looked at every single follow-up visit. So I promised you myths and truths. So here we go, and I'm going to state them as truths and putting them in a positive statement out there for you all. So in order to dispel the myths, ADHD is not a character flaw. It's not something that the child is choosing to do. And that child cannot just try harder if he has true ADHD. And what I compare it to a lot of times for my parents is because they will say, well, he can really kind of concentrate if he really tries hard, so I know he can do it. Well, that's the same as when you really muster all your forces, you can do things for a short period of time. You can lift something heavy if you absolutely have to for a moment, but you can't stand there all day and lift that thing. So the child, yes, can maybe muster his resources to manage for a little bit, but not through an entire day. Children with a fetal alcohol spectrum disorder can, and often do, also have ADHD. They may also have other things, and all of those aspects need to be acknowledged and treated. It can be either, it can be neither, or it can be both or all of those comorbidities. Children can be successfully treated for ADHD if they have a fetal alcohol spectrum disorder in many cases. Not 100%. There's nothing out there that's 100% treatable, but in many, many, many cases. It's just that the outcome doesn't look the same as if that FASD piece wasn't also there. Children with ADHD do respond to traditional ADHD medications. And I think in summary, I want to say the child with a fetal alcohol spectrum disorder, by definition of having that disorder, already faces more challenges than she should have had because it was entirely preventable, and we would love it if we could turn back the clock and make it so that that exposure didn't happen. But we can't. So she has challenges and she needs to face them. And the truth is that we owe it to our kids to make sure that we treat all aspects of their presentation to the best way that we can to allow them to use their energies and best be able to meet their potential regardless of the challenges that they are facing. So we go back to the learning objectives, and I hope that we have met them. The association between prenatal exposure to alcohol and ADHD is strong. There are a lot of complicating factors because of the overlap between symptoms as well as all of the things that are going on when a child has multiple diagnoses. And it's important for those people who are caring for a child, parents, teachers, to be able to have a working knowledge of what's going on from the ADHD side, from the FASD side, so that they can be advocates and try to ensure that the child receives the appropriate treatment from whatever area that is needed. And at this point, I think we are at the place where it is time for some questions. Yes?
Hi, this is Andy Catch for NOFAS. Thanks so much, Dr. Messer. That was a fabulous presentation with really helpful, useful information. I'm sure a lot of parents and caregivers and families are going to find it, and professionals as well will find it very helpful. So yeah, we've had a bunch of questions, so I'll just jump right in there, and feel free to type a question as well. We'll try to get to as many as we have time for. So we had a question, somebody was asking, how high is the misdiagnosis rate for FASD? Is there any evidence that it's higher for children adopted from Russia, for example? And would it be harmful for FASD to be misdiagnosed as an ADHD?
All right, so the misdiagnosis rate. So what we're talking about is a child who has been diagnosed with ADHD without recognition of the fetal alcohol spectrum disorder. Am I understanding the question correctly?
Yeah, right.
Okay, all right. So that certainly can happen. So when we look at the criteria necessary to make a firm diagnosis of a fetal alcohol spectrum disorder, in order to diagnose FAS, we have to have all three facial features, meaning small eyes, a thin upper lip, and a smooth philtrum, in order to make a diagnosis of FAS. And that's a small, when I go out to do teaching about FASDs in particular, I have a slide with a big iceberg. And what it shows is that the tip of the iceberg, that's the FAS piece. The bottom of the iceberg, which we all know is much bigger, that's the piece where the child has central nervous system effects from the alcohol but does not have those facial findings. And it's a much bigger chunk. Now, one of the issues becomes that in order to make a diagnosis in those cases, we have to have a known history of prenatal alcohol exposure. And oftentimes that's missing. So if we don't have that documentation, say for a child who was adopted from wherever, or a child who is in foster care, and we don't have that information, we cannot make a direct diagnosis. Now in our clinic, we see so many kids with prenatal alcohol exposure. We know what it looks like. And so there are many cases where if we may not be able to make the direct diagnosis, that doesn't change the recommendations that we give people for how to address those diagnoses. The harmful aspect of having a child diagnosed with ADHD without understanding that she also has fetal alcohol spectrum disorder is that it's kind of that brick wall analogy that I gave earlier, is that if all you're doing is treating the ADHD piece without the awareness of the FASD piece, then that child is not getting full treatment. There are other pieces of FASD that are going to need to be treated, and there are ways that you might be treated. Now, the medication piece, it doesn't change a lot. But the other parts of that multimodal treatment plan that I talked about, the other parts such as educational adjustments and supports and things like that, those will be missing if we don't accurately see that the child has a fetal alcohol spectrum disorder as well. One of the questions that should be asked and the explorations that should be made in many kids who are being diagnosed with ADHD is, could there be a fetal alcohol spectrum disorder going on as well? Are there signs of that?
Okay, great, thank you. And before I get to the rest of the questions, I just want to remind all the attendees that the video recording of this webinar will be made available on the NOFAS website, www.nofas.org, as well as the NOFAS YouTube channel, which is called Alcohol-Free Pregnancy. So the video with the presentation and the audio will be made available. The individual slides themselves are not available, however. So to get on with the rest of the questions, somebody was asking, are there recent studies that tie alcohol usage affecting the fetus with the father's alcohol usage?
No. As far as having a fetal alcohol spectrum disorder, let's say, is that this is the teratogen nature of this is the impact of the alcohol comes from the environment in which the fetus is growing in utero, and how the alcohol is impacting the way the brain is forming itself in utero is what causes a fetal alcohol spectrum disorder. So the father's use of alcohol is not contributing to any exposure in utero, other than if father and mother are in a relationship and father is drinking and mother then is encouraged to be drinking along with him, that can impact things. But as a direct impact, it can't cause fetal alcohol spectrum disorders because those are a function of the brain forming itself in the presence of alcohol.
Great, thanks. And could you talk a little bit about stigma issues? Somebody was asking, you find the diagnosis of FASD can lead to a certain stigma within the educational system beyond a diagnosis like ADHD, which can be more well known.
The question is that FASD, they think, carries more stigma?
Right, like a stigma within an educational system, if there's ways of dealing with that. Stigma beyond, or more so than ADHD?
Interesting, because my experience sometimes is more the other way around, that people are more resistant to the diagnosis of ADHD than of FASD. I think really the way to combat that is purely with education, because there is certainly nothing that, for either of the diagnoses, there's nothing that child could have done differently to make those diagnoses different than what she has. I think that ongoing education is essential for that. I think that teachers really do need to understand a lot of what we've been talking about here about the overlap between these diagnoses, how they can impact each other, how the teacher can do things differently for the child, both from the ADHD perspective as well as from an FASD perspective, how changes can be made in that educational system so that that child can do better. So I have found that with proper education, the diagnosis actually can be more helpful than harmful, because it really does guide people to understand why is this happening? You know, it can be very, very frustrating for an educator, for a parent, to, if they don't understand, why does this child not remember what I taught him yesterday? Or why can't he get the connection between cause and effect? And without an understanding, I think, is where it is more likely for the child to be stigmatized and to be treated as if this were just the child's choice and he's just not trying hard enough. Whereas when people can be educated to understand that it is coming from a difficulty with connections in the brain and that it's not a willful misbehavior by the child, that understanding can lead to great improvements in the school setting.
Great, thank you. So we have several more questions. Now we're getting close to 3 o'clock. So would you be willing to extend a little bit further past 3 o'clock, or have some of the questions emailed to you to respond to later? How would you like to proceed with that?
I'm happy to extend. We can keep going.
Okay, so we'll try to extend a little bit here. So one of the questions was, you talk about the role of psychotherapy, given many people with an FASD often don't have as strong an ability to gain insight into their motivations. How can that be adapted?
Well, and we have an entire therapy team here at CRT, and so we talk about that a lot. It does become very important for a therapist working with the child to have a good understanding of FASD in general and that particular child's presentation of FASD, so that they, for instance, if cause and effect is just a thing that doesn't come naturally, then adjustments need to be made in the therapy so that that skill is not relied upon for the therapy. If a child has trouble with abstract reasoning and thought, or is delayed in insight, that therapist may need to dial things back a little bit. So if you think about it, you asked about limited insight. And we have all sorts of therapies that work for children of all sorts of ages, because young children often lack that insight. And sometimes our kids with FASD may, as they're growing, not develop that insight as quickly as other children. And so it may be necessary for therapists, if they can be aware of that, to adjust their therapy down to whatever level of maturity that child can handle. And similarly, I have a lot of times that I'm sitting in my office with parents, and the statement goes something like this. They say, he's 12 years old, he should be able to, or he should no longer do fill in the blank. And this happens at a variety of ages. It doesn't have to be 12 years old. And I've sat with many people, and what we talk about is we look at the child's overall presentation and figure out on a maturity level about where is that child really. And it's oftentimes a few years behind. And sometimes it can be not behind in certain aspects, but behind in others because of that variable effect of the alcohol that we talked about earlier. But I ask parents to stop setting that expectation for the child based on his chronological age, which in many cases he will never be able to meet at that point, and just dial it back. Start looking at, so if the child is 3 years behind on his maturity level and he's 12 years old, let's start reading about, looking at, setting our expectations based on what we would see for an 8 to 9-year-old. It's not going to stay that way forever. Things are going to progress. Things are going to change. We're going to need to do an adjustment. But by doing that, we allow everyone to have more appropriate expectations for that child, something the child might have the ability to meet. Because remember, somewhere in this talk, I think maybe I didn't. I think about how frustrating it would be and how negative of an experience your life would be if you went as an adult went to work every day, the rest of your coworkers were able to do things just fine, but your boss was always correcting you, yelling at you. You always knew you weren't quite good enough. You couldn't meet your boss's expectations. That would be a miserable way to spend your day. 7 hours every day, not always knowing you just can't quite do it. And that's sometimes what our kids experience in the school setting. And I like to have teachers, and this is what we talk about with educational adjustments, but parents too, setting the expectations appropriately so that that child has the potential to succeed, and then moving forward from that place.
Great, thank you. Excuse me. So yeah, we're right at about 3 o'clock. If it's okay with everyone, we're just going to extend for a bit to go through some more of the questions that were submitted. And unfortunately, I don't think we have time to get through questions that were submitted after 3 o'clock, but we have several more that were submitted prior to 3 o'clock. We're going to try to get through as many as possible. So one was just a quick question for clarification, where you said over 50% of children diagnosed with FASD also have ADHD. Is that correct?
In our clinic, we see somewhere between 50 and 75%, yes, depending on the study population that we look at.
Okay, great. And somebody was asking about what if a child has an oppositional disorder and so they're not interested in working with a service provider? How can that be accommodated?
Well, that's a little bit, I would really need clarification on that question, because the talk is about ADHD and FASD. So if we're talking about a child who's been diagnosed with with ADHD, FASD, and ODD, oppositional defiant disorder, that is one thing. If we're talking about a child who's only been diagnosed with ODD and a fetal alcohol spectrum disorder, it becomes more difficult. And honestly, one of the first things that I would say is to make absolutely certain that that child does not also have ADHD, because ODD is one of my, I will say it's one of my least favorite diagnoses. And I think the reason for that is it's an accurate diagnosis, and we do make it at times, but one of the things I always want to make sure has happened in a child who has been diagnosed with ODD is that someone has looked very, very carefully to find out, are there reasons behind that child's oppositionality? And the reasons can be myriad. It could be untreated ADHD, it could be unrecognized FASD, it can be a variety of other things. So the first step is making sure the diagnoses are correct, and then looking, for ODD, it has to be individualized for that particular child, how you're going to address that if that really is the only thing going on.
All right, great, thanks. And someone was asking about if you have a treatment plan that's been given for children or youth with an FASD who also have parents with an FASD or an ADHD, if that has an impact.
Can you repeat that question for me?
About treatment plans for children or youth with FASD who also have parents who have an FASD or possibly ADHD as well.
Well, if you're going to put together a treatment plan like that, you better, it's very similar to what we need to do when we're putting together an educational plan or a treatment plan. We need to make sure that everyone understands it, that it's written at the appropriate level, that it's discussed at the appropriate level, and that we get feedback to make sure it's understood. So if we have knowledge that a parent, for instance, has a fetal alcohol spectrum disorder, him or herself, then we need to make sure that we adjust things just as we want people to adjust things for the child. Meaning, if there are issues with abstract thinking, if there are executive functioning problems, we need to be very concrete. We need to understand that person's cognitive ability and make sure that they are able to understand what we're asking them to do. We may need to make an adjustment by putting together a chart or some sort of visual structural aid, all sorts of things that need to be done to support that particular parent just as we would do similar things to support a child in a setting who also needed that kind of external support for success.
Thank you. And there was a question about epigenetics as a contributing factor in FASD. Do you have any experience or information regarding that topic of epigenetics to share?
No, not in relation. I do not in relation to prenatal alcohol exposure. There's a lot of that going on in relationship to trauma, which would be a different area than what we're talking about. Epigenetics basically means that a change in the DNA that happens after birth is then transmitted to the child, essentially, to kind of oversimplify things. But no, I do not have a lot of experience in how that relates with FASD.
Thank you. And we had a question about if there's ADHD medication alternatives for preschool age children around ages 3 to 5.
Well, there are alternatives. They're the same as far if we're looking at medication alternatives.
Yeah, this person was saying that they talked to a medical provider that did not want to start a stimulant until at least the age of 5.
Yeah, I see that frequently, and honestly, none of us particularly love treating preschoolers for ADHD. Number one, there was a slide about this. Number one, it's tricky. Our little kids, they respond differently. And sometimes we can choose a different medication if there is a different target aspect, particular target symptom. If it's all about the hyperactivity, we might be able to choose a different medication. But if we're looking at full-blown ADHD, and in my experience, if that ADHD is putting that child at significant risk. So the issue that comes here is that the range of developmentally normal behavior in children who are 3 and 4 years old overlaps a ton with the behavior that's identified in children with ADHD. So you have to look very carefully at that piece that was in the slide. Is the behavior within the range of developmental norms? And if it is, or if it's even close to it, we're probably not going to be treating that as ADHD. But there are cases where kids, they are really, it's very much interfering with their functioning. It's placing them at significant risk. And in those cases, we will very carefully, with even closer follow-up than normal, treat the ADHD. But honestly, in those cases, most of the time, and not all of the time, mind you, but most of the time we are looking for the optimal treatment, which usually still is very careful management with a stimulant as a first step. Now, as a second step, if that is not, and if that's not effective, if the child doesn't tolerate that, which can be the case more so in very young children, then we can move on to the alpha agonist medications, which can also be helpful.
Thank you. And we've gotten a few related questions of parents expressing difficulty obtaining a diagnosis for an FASD, asking advice on how to find a doctor familiar with FASD, or asking if they live in a place where there are not many or any FASD-informed physicians, what recommendations may there be for parents about advocating for their child to get an FASD diagnosis, or advocating within the medical community?
Well, if there really are no providers who understand FASD, then that person cannot be expected to make a diagnosis that they don't understand, honestly. I am working with a group through the American Academy of Pediatrics to expand education in the primary care community about fetal alcohol spectrum disorders. NOFAS obviously is a great resource for that. But the truth is, we have people who come to CRT from very far away, many states away at times, for a full assessment because they have difficulty finding that assessment closer to home. And I hope that as we continue to provide education, resources, awareness through all aspects, I hope that that will change. But at the moment, that's where we are.
Great, thank you. And yes, yeah, NOFAS has a resource directory on the NOFAS webpage that also has a list of many diagnostic clinics and resource providers. So that's on nofas.org, and there's a link for the resource directory that's organized by state. So that's a resource as well, because we at NOFAS definitely hear that a lot. Also, there was a question about if the symptoms overlap, as you were talking about, between FASD and ADHD, and the medication may be the same. How do you know, or how can you know that something's being caused by FASD?
Well, and therein is the piece that part of that optimal medication management profile is to have a physician who's familiar with both diagnoses. And it's a process that happens as we are moving through the management process, as we are starting medications and observing responses. Sometimes that's the place where we begin sorting out what's going on. But I work with a team of really good psychologists with lots of experience, and we do measures and testing and all sorts of stuff where in the course of that evaluation, we can often use our professional experience to sort things out a little bit better. And trying to give a list of how we do that really is impossible, because what I told you before is very, very true. If I give you a checklist for FASD and I give you a checklist for ADHD, they're going to look very similar. They are going to, as just a kind of a basic understanding, even from a physician's perspective who perhaps doesn't understand or isn't familiar with FASD, they're going to kind of lump them all together. It's the nuanced part of trying to kind of sort those out through continuing education and through a lot of awareness of FASD, ADHD, and responses to medications. And one of the things we always remind people is that as we go about the process of treating the ADHD, to remember that it's only going to treat those aspects that come directly from the ADHD. It is not going to fix, say, the executive functioning piece that's coming from somewhere else, from the prenatal alcohol exposure, is that those pieces are not going to respond to the medication. And yet the objective is that we will be able to, with medications, fix significant pieces of the child's presentation that is inhibiting her functioning.
Great, thank you. Thanks so much for taking the time, some of this extra time to answer some of these questions. There's a few additional questions, if that's all right. One was if you were able to talk about some of the similarities between FASD and trauma disorder.
Mm-hmm. I'm sorry, the question is similarities between FASD and trauma?
Right, are there a lot of similarities between those?
It's similar, yeah. Well, FASD and trauma. There's a lot of overlap between ADHD and trauma, and that is a piece that people are working on very much, is to make sure that we are all trauma informed, that we understand that kids who have experienced trauma may present as inattentive or hyperactive or all of these pieces that look like ADHD. And once again, I want to stress, they may be ADHD. Just because you have a fetal alcohol spectrum disorder, similarly, just because you have a trauma disorder does not in any way mean that you cannot have ADHD as well, and that ADHD piece may not be impacting you. It certainly may. But yes, there are a lot of things that look similar, and the ADHD looks similar to the FASD, looks similar to some of the findings that we will see in kids with trauma. And again, that's part of what we do in our evaluation, is try to pull those pieces apart and explain where they may come from and how best to address them.
Thank you. And there was a question about stimulant medication. Somebody was asking, are there any negative effects of stimulant medication when an adolescent becomes an adult? And sort of related, there was another question about if a mother was taking a stimulant during pregnancy, could that have an effect on the developing baby?
Okay, so those are two separate questions. So when we are looking at treatment with stimulants, there is conflicting information. One of the things that we do is monitor very carefully growth, because the stimulant can suppress appetite and in some cases may inhibit height attainment to a small amount. It's usually not significant, but it is something that, for instance, in my clinic, I monitor very, very carefully. As far as prenatal exposure to stimulants, I would suspect that an OBGYN would be having someone taken off of a stimulant, if at all possible, during pregnancy, simply because of the unknown effect on the baby.
Great, thank you. Let's see. So that's pretty much most of the questions. Just in closing, some people are asking if you were able to direct people that want to learn more regarding ADHD and FASD. Are there any books or literature or other resources that people may be directed to in closing?
To learn directly about the overlap, off the top of my head, I do not have the exact resources that we use. So I would say, and for some reason I cannot get this slide to advance further, but on our website, which is listed on my next slide, we do have some resources. Oh, maybe it's not. So the website for our clinic is Children's Research Triangle, all one word.org, and we do have a resources section there that might be helpful.
All right, thank you very much. We really appreciate it. And this is a great presentation, very useful information. Again, I'm Andy Katcher, Communications Director at NOFAS. And again, the video recording of this webinar will be available on the NOFAS webpage and on our YouTube channel, which is called Alcohol-Free Pregnancy. And that video will be posted within the next 24 hours or so. As well, some people are asking about slides. Again, the individual slides are not going to be available. What will be available is the video of the presentation with the audio and video on our YouTube channel. And you are definitely welcome to connect with NOFAS on our social media pages to learn more about our upcoming webinars, other information for NOFAS. We have a very active presence on Facebook and Twitter. And you can sign up for our weekly email newsletter by signing up at nofas.org, the NOFAS Weekly Roundup email. And yeah, thank you very much to our presenter, Gwendolyn Messer, and I'll just turn it over to her if she'd like to say anything in closing.
Well, thank you all for joining me. I hope that this has been helpful. I finally did figure out how to advance this last slide. So my email address, our contact information is there if we can be of help in any way. And thank you all for attending. Please pass on the information about both the fetal alcohol spectrum disorder, the ADHD, all of the challenges our kids face. I hope will be shared, because I tell people all the time that I think that one of the biggest ways to make inroads into this is to get out there and continue to educate people, and then those people go on and pass on that information, and people become more knowledgeable and more effective in helping our kids.
Great, thank you very much. Thanks, everybody.
You are welcome. Everybody have a good afternoon.